So, Dr. Sampson, thank you for staying on with us. You mentioned right before I hit the record button that your research has kind of focused on the effectiveness of the safe haven law. Could you please elaborate?
Sure. So the research that exists right now about the safe haven law is that it was a law that was passed in 1999 here in Texas is where it started and it has now spread to all 50 states. And the purpose of the law is to provide an option for people who cannot take care of the infant or do not want the infant to drop off the infant at a designated safe space. That law was passed in 1999 with basically on the premise that this would be an option. It might help to decrease unintended births and pregnancies. However, the problem is, it is done anonymously, and we really don't have data that can correlate and that can show has it been effective in decreasing the number of abandonments that are like what we've seen here, where they're abandoned in ditches and in environments where they can't possibly survive. So unfortunately, we can't really draw any conclusions about the effectiveness. I also looked up in Texas, the Department of Child Protective and Family Services. They're saying that there were about 79, no, I'm sorry, I think it's 69 infants that have been surrendered safely in the last 5 years. And to give you some context of numbers, just in Harris County, we have nearly 60,000 live births a year.
Mhm.
So then you look at those numbers, it's a very small percentage who is taking advantage of that law. And when I was looking at the research about why that might be the case, it's true that a lot of people probably don't know about it. But I think something really important to pay attention to on the policy side is that this was a policy that was passed with no funding. So here we are 25 years later with a law in place that has no funding to be promoted, to be in the general public awareness. So a lot of people do not know about it. There's probably a lot of confusion because also the policy and the policies surrounding it differ state by state. So in Texas, you have up to 2 months where you can surrender a newborn at a designated safe haven. And here I think it is hospitals, certain hospitals, fire stations, and
Freestanding emergency rooms.
okay, thank you. Freestanding emergency rooms. So 60 days, that's longer than a lot of states. So that is a compassionate policy. However, there are some stipulations that I think have created some confusion and fear, probably. And one is that you have to provide medical history for the infant, and you have to be aware that that newborn will be investigated as a missing child. So that's going to require that somebody who receives the infant is asking somebody that has dropped off the infant questions. And that kind of inquiry and investigation, they use the word investigation, just strikes fear in communities that I've seen. And in fact, when I started researching this issue, I always go talk to my former program director, Lysandra Noyle, who is very familiar with the communities. She ran my University of Houston Healthy Start. And I asked her, what do you think is going on here? And she said, after working with hundreds and hundreds of women over the years, this to me looks like young girls that are scared and have been in denial of having a baby, and they just need to get rid of it quick. They aren't thinking straight. It really reflects the decision making of somebody really young and panicked. And I also think that those people are not going to connect the dots about a law that exists like this. And they probably aren't, they really aren't looking for those kind of solutions. They're just looking to make it all go away.
Mhm. Well, but regardless, is how can we begin to prevent this from happening? I mean,
Right.
aside, we know that there's research being done, but oftentimes it seems like there's a lot of resources available. There's just not enough outreach, or when there is, it's not reaching the people it should be. So how can patients
Absolutely.
and doctors perform their due diligence when there's still things like digital divides or scholarly work published in journals whose primary audience, with all due respect, is other scholars?
Oh, absolutely. Absolutely. It gets trapped in the ivory tower and we're just kind of in an echo chamber a lot. One thing I really like about I'm at UH and I'm at Baker. The Baker appointment is like a fellowship. And one thing I really like about Baker is they're very focused on just policy, right? Because what I see happen with policy is that it's not being communicated on a community level. Another thing that I see happening, and I love this question because I was going to say that some commonalities I see as far as why this kind of thing is happening and will continue to happen, and why we have communities of color who are dying at higher rates during childbirth. That's existing too, right? There are some commonalities. And one is exactly what you're talking about. It's ineffective messaging. So the messaging about these solutions really is not usually culturally, linguistically, educationally relevant. A lot of women get their information about reproductive health from their families, from their friends, from TV shows. They aren't out there reading peer-reviewed journals or really even knowing what to ask at the doctor. So I think that if we want a society that is healthier, which is absolutely critical, if you want safer communities, we've got to have healthier communities. And the community needs to have more of a voice about how they can access healthcare options. And I think that I would love to see policies that really come with funding and that enforce community-based messaging. There are
Let's
plenty of experts in the community that we could be accessing, is what I'm saying, not just in the academic circles. Like there are experts with lived experience who can tell us how to better message and get the word out.
That makes sense. But let me also bring it back to something you brought up, being that voice. How do patients, especially those of color, be a voice for themselves with healthcare experts? Nobody likes being told how to do their job, with respect to as well Dr. Google being the main doctor everybody sees. But
Sure.
when there are experts, but sometimes there's that stigma of speaking out when something just doesn't feel right.
Yes. That has been a learning curve for me. I must say, it has been really sad to see just thousands of women feeling disempowered and their partners feeling disempowered in the healthcare process. And what I'm trying to encourage people to do is, it is true that the person that you're seeing went to, several years of school. They absolutely are more an expert on pathology and the medical side of things. But you as an individual are an expert in your own body. And that, again, is why it's so important to provide education about reproductive health. Half of our population is female. Our reproductive health care span, I'm sorry, not healthcare, our reproductive health span takes up about 4 decades of our lives as a female. And to have that neglected and to not educated about the full spectrum of reproductive health, as far as when you're having severe pain, this is not normal. When you're having bleeding or when you're not having bleeding, that can mean that you're pregnant. All these basic health information, it's not spread. It is not universal. It's a matter of access, right? So I think that that's what I'm trying to encourage people to do is when you go to a healthcare provider, you can keep in mind that you need to be the expert in how you describe what's going on. You need to be the expert in advocating for yourself. You need to be the expert in educating them about you. They're trying to educate you about symptoms and options, but they don't know how it feels in your body. So I think that feels a little bit more comfortable for people is you don't have to know the solution. You have to be very good at describing the problem to your provider. And if they are not listening, you have got to find a different provider because that can be deadly, especially during childbirth.
Speaking of decades of research, health disparities among different
Mhm.
racial and ethnic groups aren't new topics, but
Nope.
can you tell us about just a few or some significant changes that have come as a result of research experts like yourself that have done to address or bring awareness to these disparities?
Mhm. It's a great point. We have known that racial disparities in health have existed for at least 25 years. When I look at the research, it's really a lot of time was spent regurgitating the problem, identifying the problem, it being called health disparities instead of racial disparities. Um, and this is similar to the abandonment issue. I think what happens often is that we as researchers and people as policymakers are asking the wrong questions. We're not asking why. Why is this persistent? Why with maternal mortality and infant mortality? Not only has it kind of inched up, right? These racial disparities have persisted and are increasing. Why is that? We really need to be looking at that question. And I also think that I don't think this is a fact, that there has been a lack of inclusion of lived experience, which is super important when it comes to things like racial disparities. Research in general is driven by science, first of all, which is great, but it's also driven by the humans that are conducting the research. And by and large, the people who were doing research on health, particularly, were males, and it was about male health. So we're already behind in women's health, and then we're really behind on reproductive health. Um, that's my answer is that when we look at what has happened and what has changed, the biggest changes I see are really within the last 5 years. It hasn't been that long when there has been more representation by people of color who are physicians, who are researchers, and that are saying, hey, wait, we're leaving out this whole group of people when we are talking about this issue, or we're not messaging it in the right way. And now we're starting to see more push for maternal centric care, right? Instead of just sending her to all these different places and then her infant goes to all these different providers. There is more of a push to include the mom in the decision making, and those kinds of things are happening, and to include other options and alternatives for care, like community education, instead of just having education only available at the doctor. We need to get in that community.
You know, I don't know how to ask this question without it sounding abrasive, but
Okay.
I'd like to kind of end with something positive. This is a heavy topic, you know, and
Yeah.
as someone who doesn't have children,
Mhm.
but did grow up spending most of his life without health insurance, how do
Mhm.
we move forward in having hope? I'm honored to have friends now in my current atmosphere in the healthcare industry who genuinely do care about their patients, the work that they do.
Yes.
But for those that don't have that luxury, how can we reassure our viewers with that bedside manner that doctors have trademarked that everything is going to be okay?
Mhm. Yeah, I do think it is positive. I mean, I'm sorry, important to have a positive outlook. And again, I love that you asked this question because we do tend to focus just on the negative, and that's what we have spent decades doing, being like, here's the trend. It's like, okay, so what are the realistic solutions?
Mhm.
What are the realistic solutions? And I think empowering the communities and empowering patients is realistic. I think that the more people we have who can come come off of that, they call it like bedside to bench, right? To come off our bench from academia, from medicine, and to go to the bedside, to go to the communities, to invite key community members, to pay community members. If you're going to ask them for information, hey, how can we educate you better? Pay them. These are people whose information and experience is valued. They may not have a PhD, but their information and experience is valued. I think another thing that's very effective in the maternal and infant space is highlighting the stories of survivors. And every mom that tells a story of surviving a near-death birth she tells the story of some provider on that team listening to her. It's really that simple. It's really creating some curiosity and listening to what the person is saying about their body and their cues. So I think it's people educating themselves and valuing their own experiences. And we continue to help people speak up about their experiences. And it's a supply and demand thing. If the consumers start demanding that they are heard and that their expertise in their own lives and their body is heard, the supply will listen. Every doctor I've ever spoken to got into medicine because they want to help people. And then they're put in situations also where they have to make incredibly difficult decisions with very limited resources. We do not have enough funding for Medicaid providers, even though 51% of Texas births are Medicaid financed. So when somebody goes to look for a Medicaid provider, it sounds so simple. You have Medicaid. Good luck finding a provider that's taking new patients. Good luck getting on Medicaid in the first trimester so you can get that early prenatal care, which helps tremendously. So it's, we are working in a landscape of depleted resources, flat funding. So until that changes, we really need to rally together as community. And Houston's great at that. We need to encourage each other, to help each other, to talk to. I'm sure that you, being somebody with lived experience of no health insurance, I bet you are a great advocate for how to get what you need when something is hurting. You've learned to be resourceful, and then you're probably helping other people learn to be resourceful. Is that an accurate guess? I don't know.
I'm good for other people. I neglect my own.
That's so common. It's so common, and I think that it's a beautiful thing that we want to help others. But you also have to turn it on yourself and advocate for yourself, because if you become unhealthy, then those 5 people that you helped are no longer helped.
No, you're absolutely right. I was hanging out with a doctor friend of mine. We were just throwing some drinks back, and then I got a cramp in my stomach, and he's like, "Are you okay?" I was like, "Yeah, I have these all the time." And he's like, "What?" And then I said, "Oh my God, you're a doctor. I should." But it was just like yeah, I've dealt with this for more than half my life. And he's like, "No, let's set up an appointment." It's like, "Do you accept new patients?" "I will accept you as my new patient. It's fine. Make an appointment." And it was fine. We still never got it resolved, but that's a whole nother situation. But
Yeah, but that happened because of a relationship. That's what I want to point out. That moment happened because of relationship building. And if we can do more relationship building across our community and empowering them and talking to the physicians, hey, and talking to them realistically. I know you have to see 20 patients a day because of demands. So how can we train you to be able to convey compassion and listening in the 3 minutes you have with each patient?
That's a good point. Shout out to Dr. Ali for making time for me.
Yeah.
Is there anything else you'd like to add?
Well, I mean, I think that it's very important to have these conversations. And I think it's really important for the interviewers to ask questions like yours, which scratch the surface. We often just have these conversations kind of like in a blame focused way, because abandoning a newborn that, still has an umbilical cord attached is shocking. It's horrific. It upsets everyone, including the person who did it. It's traumatic. It costs money. It has all these negative consequences. But we focus just on that instead of really opening up this box to ask, like, what can be done. And I think it's really important for interviewers like you to bring up your personal experience of the difficulty and the gap between science and knowledge. Because what I have noticed, I've been in Houston for 15 years and working these projects that I had in the community, and the range of health literacy, meaning what a person understands when I hand them a brochure or when I tell them about healthcare. The range of health literacy is shocking. And they can even be in the same community. Somebody knows about prenatal care and knows how much a doula can help save a woman of color's life. And then you've got another person who lives a couple blocks away, or maybe is in the same race, age group, that kind of thing, and has no idea and thinks that the doctor is going to harm them and doesn't know how they got pregnant. So that has got to be dealt with realistically.
Understood. Is there anything else you'd like to add?
No, I really appreciate the opportunity.
Same here. We'll leave it there then. Dr. Sampson, thank you so much for taking the time. We appreciate it.
Thank you.